Hello, Assalamu alaikum. It's me, Dr. Muhammad Kazafi. I want to present one more case. You are watching Dr. Muhammad Kazafi Views. Assalamu alaikum. Good morning, where there's a morning. Good evening, where there's the evening. My today's topic is that provocative discography. For this, I want to present one case for the analogy to attract your interest in this topic. As you know, the 30-year-old male present for the evaluation of the chronic low back pain with secondary complaint of the neck pain, headache, dorsalgia, hip pain, polyarthralgia, polymyalgia, and regional sensory disturbances. Her daily pain is 10/10, and she points to widespread area from the T4 level down to coccyx and on both sides of the midline. Aggravating and the relieving factor are unclear. She has a past medical history of seizures, irritable bowel disorder, temporal mandibular joint disorder, major depressive disorder, and the post-traumatic stress disorder. Social history is pretend for smoking, unemployment, and childhood sexual abuse. There are multiple somatic complaints on the review of the systemic Ovastry disability index score is 40 points, and as you know, the 80% is equal to severe disability. And her pain diagram is non-specific. Medication include oxycodone, extended release 40 milligram 3 times daily, carisoprodol, and diazepam, also the medication for him. Examination yield a flat effect or kinesiphobia, widespread tenderness, and the effort-dependent strength testing. MRI of the lumbar spine demonstrate disc bulge at the L3 to L5 and a small midline protrusion to L5 and S1. He has had several procedures by the another pain clinic which did not help for more than 1 to 2 weeks, and he states he was informed and he would need a discogram to figure out what is going on at this point, and request that it be performed. Which of the following we can do? Actually, you know, if the decision were made to proceed to the lumbar proactive discography, this patient is at a high risk for false positive results. And you know, the provocative discography is a diagnostic procedure that is not indicated in the routine evaluation of chronic lower back pain, and there is nothing in this patient's history to suggest that she has a feature of discogenic lower back pain such as focal pain at the midline, flexion and sitting intolerance, and pain aggravated by Valsalva maneuver. Further, there is no mention of how results, if believed, will be used to guide treatment. The patient has an abnormal non-anatomic pain map, a history of widespread chronic pain, and probable somatization which put her at a very high risk of a false positive result. Other common cause of the false positive results include the history of the prior back surgery and failure to utilize manometry or a control disc during the performance of the test. Giving her clinical presentation include severe psychological, psychopathological, widespread chronic pain, and radiograph findings that do not correlate well with history and physical examination. The performance of any diagnostic test to attempt to determine a pain generator is probably unwise. This usually will fail to accurately uncover a pain etiology or may produce a false positive result that may lead to further unhelpful procedure or surgery. This patient is at high risk for the iatrogenic injury and will almost certainly not improve with her current treatment regime of medication and procedure. Even if her L5 to S1 protruded disc were symptomatic, it does not explain the balance of her symptoms, so the treatment aimed at it will fail to improve her overall function. This patient may do better in a functionally based rehabilitation program that include education, physical therapy, and behavioral health. In her case, the biomedical model reliance and of medication and procedural or surgical intervention should be emphasized. I want to a little more explain here regarding the proactive discography, which is important. In that regard, the proactive discography is an invasive diagnostic spine procedure that involves the administration of a contrast into the nucleus pulposus of an intravertebral disc to determine if the disc is the origin of the patient's chronic spine pain, and the test is based on the premise that an intervertebral disc can be source of spine pain, that the pain is experienced when the disc is mechanically loaded, and that therefore similar pain will be experienced when the disc is pressurized with injected contrast. Actually, we have to describe here what is the pathophysiology associated with the intervertebral disc injury. We want to describe the classical presentation of discogenic lower back pain, and I want to outline the indication for the proactive discography, and I want to explain the importance of the collaboration and communication amongst the interprovincial team to ensure the appropriate selection of candidate for proactive discography. Provocative discography is an invasive diagnostic spine procedure that involves the administration of the contrast into the nucleus pulposus of an intervertebral disc to determine if the disc is in the region of the patient's chronic spine pain. The test is based on premise that the disc can be source of the spine pain and the symptomatic internal disrupt disc cause pain when it is mechanically loaded. Therefore, it should be similarly painful when pressurized with injected contrast. As you know, the anatomy and physiology, little bit about the intervertebral disc functions. You know the intervertebral disc function to distribute pressure evenly across the spinal segment while allowing for flexion, extension, and rotation. The inner portion of the disc is called the nucleus pulposus since it is comprised mainly of proteoglycan network and hydrated gel. It provides most of the shock observing properties. The outer covering of the disc is the annulus fibrosus, and it's comprised of several layers of interwoven collagen that anchor the disc to the vertebral end plates and are oriented in such a way as to allow for reinforcement and rotational stresses. Fissures can form in the posterior and posterolateral segment of the annulus fibrosus that allow the nuclear material to extrude through. The outer third of the annulus is richly innervated, and the nuclear material may sensitize these nociceptors so that even relatively minor mechanical insult can be exquisitely painful. Historical and anatomical feature of the discogenic spine pain from the symptomatic lumbar disc is usually midline and often refer laterally across the back or into the buttock and posterior thigh. Occasionally, it may refer to groin or below the knee. Typically, discogenic lower pain is produced or aggravated with prolonged sitting, forward flexion, and transitioning from a sitting to a standing position, sit-ups, Valsalva maneuver, and rotation while subject to an axial load. Pain originating from the cervical or thoracic symptomatic disc is less well defined regarding the typical distribution and aggravating and relieving factors. Supporting advanced imaging, there are imaging findings on MRI that predict with the fair sensitivity and specificity discogenic lower back pain. These are the presence of a high intensity zone synonymous with the extrusion of the nuclear material and superimposed on a disc bulge. Modic changes greater than 1/3 of the adjacent vertebral body height and significant disorganization of the nucleus resulting in the appearance of the dark disc on the T2 weighted image. The indication for the provocative discography should only be employed when there is a moderate to high pretest probability that the spine pain is suspected to be diagnostic origin, and this is based on the historic and the advanced imaging finding. The information obtained from the test will be used to rule out or plan subsequent treatment decisions such as therapeutic intradiscal procedure, for example, intradiscal electrothermal therapy, annuloplasty, biochroplasty, regenerative medicine or surgery, or disc arthroplasty. Contraindication: it is not indicated in the routine evaluation of non-specific chronic pain when adequate conservative management has not yet been attempted in earnest. And in case where intervertebral discs appear radiographically normal, consideration should be given to withholding provocative discography in patients with the substantial psychosocial stressor or poorly controlled mood disorder, as there may be excessive risk of the false positive result. The contraindications that apply to the other invasive spine procedure apply equally to the provocative discography and include patient refusal, untreated infection, coagulopathy, and thrombocytopenia. Additionally, patients with an allergy or both the iodinated and non-iodinated contrast are not a candidate. Technique or the treatment: the Spine Intervention Society, also formerly known as the International Spine Intervention Society, has laid forth thoroughly research practice guidelines that the provocative discography is preferred in a procedural suite with X-ray fluoroscopy. The patient is positioned prone except in the case of cervical discography where they are supine, and the chloral hexadine-based prep and occlusive drape should be utilized. Intravenous antibiotics should be administered before skin puncture, or intradiscal antibiotic may be used, or both, according to the condition and the requirement of the patient. The performing physician should perform a surgical scrub and don a sterile gown and double gloves and not touch that distal portion of the needle that will be entering the disc. Only Light sedation, if any, is preferred. This procedure can be performed under local anesthesia or by additional administration of the oral Valium to help ensure that the patient is relatively comfortable but not heavily sedated, since real-time accurate patient feedback is essential. Under fluoroscopic guidance, the nucleus pulposus of each disc to be tested is entered with the smallest gauge needle possible, and typically we choose 22 to 25 gauge spinal needle, and the discs are then subsequently pressurized with contrast, and the patient's response to pressurizing of each disc is noted. If pain reproduced is of adequate severity and similar in quality to the patient's usual spine pain, the test is deemed concordant. However, if pain produced is dissimilar to the patient's usual spine pain, the test is discordant. So the provocative discography results are valid if all of the following criteria are satisfied. The patient is alert enough to relate information reliably. Manometry is utilized for each disc tested, and the radiographically normal control disc does not produce concordant pain when pressurized. Some authors have advocated adding local anesthetic after provocation portion to improve diagnostic accuracy, but the literature is conflicting. At the conclusion of the test, the patient may be sent for the post-procedure non-contrast CT scan, which allows the evaluating physicians to better appreciate disc morphology as compared to the fluoroscope alone. Complications, definitely all procedures has complications. Likewise, the provocative discography has a risk of infection, discitis or osteomyelitis, bleeding, dural puncture, acute disc puncture by overpressurization with contrast, and worsening of disc disruption, degeneration, persistent post-procedural pain, allergic reaction, and damage to structure encountered during the needle placement, such as the spinal nerve or kidney. The clinical significance of provocative discography. The several decades have passed since the advent of the provocative discography. Arguably, it is the best method to determine with reasonable certainty the presence or absence of discogenic spine pain. Yet its utilization has declined for several reasons. First, provocative discography is an invasive test and therefore carries risk, including the concern that structural integrity of disc tested may be compromised, leading to premature or more rapid degeneration. Second, although the provocative discography is widely criticized by having unacceptably high false positive rate, much of this controversy stems from earlier literature or reanalysis of the data of the members of Spine Society found that in patients without a somatization disorder or prior back surgery, the false positive rate per disc is in the mid single digit, but only when performed the strict adherence to the published and Spine Society guidelines. The third thing, the provocative discography is unreliable in predicting spinal fusion outcome when performed to relieve chronic pain or chronic spine pain. It may, however, be unfair to judge the worthiness of the test by surgery with known low to moderate success rate for this indication. Finally, MRI has vastly improved the ability to define disc morphology, and some MRI findings such as the high intensity zone and the modic changes correlate with the probability of the discogenic lower back pain to some degrees. How to enhance the healthcare team outcome? Provocative discography is often done by the orthopedic surgeon or neurosurgeon or the radiologist. While there are potential shortcomings of it, use a discogenic diagnostic tool. Provocative discography may still be ideal test in following situation. First, when this is more than one abnormal intervertebral disc, particularly when several harbors finding on MRI that beg the question so that which might be the patient's primary pain generator, and second, when the next step is in treatment holes. The potential for the significant morbidity such as spinal fusion surgery, especially to determine if the disc adjacent to the proposed instrumented segment is painful or disrupted. The primary care provided include the nurse practitioner should educate the patient on the limitation of the test. In some cases, imaging with MRI may be the better option as it is more relieving and certainly less painful. So that's all from the provocative discography. I was thinking it should be a small video is enough, and it is also registering. I hope you will like it, subscribe it, and share it. Thank you so much.